Welcome back to the deep dive. If there's one chronic pain dilemma that seems to touch almost everyone eventually, it's got to be knee osteoarthritis, or OA.
Oh, definitely.
And if you have it, you really know that impossible choice.
Yeah.
Do you struggle with long-term pain medication or, face the prospect of major joint replacement surgery down the line?
That gap is enormous. Patients are often quite desperate for something non-invasive, something that actually works without all the side effects of taking daily drugs.
Exactly. So our mission today is to really dig into some fascinating preliminary results from a highly controlled trial. It was just presented at the ASTRO Annual Meeting 2025.
Right. ASTRO being the big radiation oncology society in the U.S., so this is significant.
It is. And this study, it's coming out of Korea, and it proposes, well, a surprising middle path. A single round of low-dose radiation therapy, or LDRT, for relief in mild to moderate OA.
Yeah, the core idea here is that we might be able to use LDRT to sort of suppress the underlying inflammation that drives OA pain, offering a safer, more conservative, non-invasive option. So we're going to unpack the evidence, right? Show that this therapeutic benefit is actually real and prove it works above and beyond that powerful placebo effect you always see in OA research.
Precisely. That's the key challenge.
Okay, let's unpack the sheer scope of this clinical need first. We talk about OA a lot, but just how big a health problem are we really dealing with here?
Oh, it's massive. Globally, I mean. Just in the United States, OA is the most widespread form of arthritis. It affects something like 32.5 million adults.
Wow.
And it's progressive. It's debilitating. The cartilage, the cushion in the joints, it just deteriorates. That leads to pain, stiffness, and it really diminishes quality of life severely for many people.
And the current management path, it just feels so inadequate for so many people, doesn't it? Early on, okay, you try physiotherapy, lifestyle changes, maybe some basic painkillers.
Right.
But as it progresses, surgery, specifically joint replacement, often feels like the only eventual and pretty irreversible option left.
That's the core problem highlighted in the source material, actually. Dr. Byung-Hyu Kim, who led this Korean trial, really emphasized this. This severe clinical void. We critically need interventions, moderate ones, that kind of sit between, relatively weak pain medications and really aggressive, costly surgery. LDRT is being looked at precisely for those patients who maybe don't tolerate injections well or have issues with long-term drug use.
That makes a lot of sense. Fill that gap. Okay, but we have to address the R word here. Radiation. When people hear radiation therapy, they immediately flash to high-dose cancer treatment, right? We need a major misconception check on LDRT.
Absolutely. That's the natural assumption. Therapeutic radiation is always high-dose, potentially damaging. But look, that's simply not the case for LDRT applied to joints like the knee.
It's just a different scale entirely.
It's completely different. For conditions like OA, the dosage is reduced, well, dramatically.
Can you maybe give us an analogy? Just how much lower are we talking?
Okay, think about the unit, gray or Gi. A typical cancer radiation course might involve tens of grays delivered over many sessions.
Right.
In this Korean study for knee OA, the doses used were less than 5% of what's typical in cancer treatment. It's like comparing a single sip of water to trying to empty an entire swimming pool. It's a minimal, very localized exposure.
Less than 5%. Okay. And focusing on safety then, does the location, the knee itself matter? Is it inherently safer to treat than maybe a hip or somewhere closer to the body's core?
It absolutely does matter because LDRT targets these peripheral joints like the knee. They're positioned away from vital, more radiosensitive organs. So the inherent risk of severe side effects is significantly lower just by anatomy.
And did the trial bear that out?
It did. Crucially, this trial confirmed that safety signal. They observed no radiation-related side effects at all. None. In the entire group of patients.
That's pretty remarkable, especially since, you hear about LDRT being accepted in other parts of the world. Why has the U.S. maybe been slower if it's common in places like, say, Germany or Spain?
That's a really important point. LDRT isn't some brand new concept in Europe. It's used quite a bit in clinical practice there.
So why the skepticism here?
Well, the reason the U.S. medical community has been, let's say, cautious is precisely because of the lack of this kind of high-quality sham-controlled data. Until now, the evidence just wasn't rigorous enough to meet modern standards. This Korean trial is aiming to provide exactly that level of evidence we've been missing.
Got it. The robust placebo-controlled proof.
Okay, let's dive into the core of this trial then, because the design, as you said, is what really allows us to trust these results, especially when you're dealing with that massive placebo effect in OA research. Walk us through how Dr. Kim and his team actually set this up.
Right. So they established a multi-center trial across 3 centers in Korea. They enrolled 114 patients, all with moderate to mild knee OA. The really key thing was that they were blinded, didn't know which treatment they were getting, and randomized into 3 different groups.
Okay, and those groups were 1 getting a very low dose, just 0.3 Jack.
1 getting the proposed therapeutic dose, 3G, and the crucial third group, the placebo or sham group.
Exactly. And the placebo, the sham group, this is where the cleverness of the design really comes in. These patients went through the exact same setup process. Positioning on the table, time under the machine, all the sounds, everything.
But the machine just didn't deliver any radiation.
Precisely. No dose delivered. Everyone got 6 sessions, total blinding.
Now, when you're evaluating success in an OA trial like this, you can't just ask, hey, are you feeling better? Right? You need a proper scientific yardstick. What framework did they use?
Yeah, they used a pretty robust metric. It's called the responder criteria. To count as a success as a responder, a patient had to show a meaningful improvement. Not just any improvement, but a meaningful one.
In what areas?
In at least 2 out of 3 key areas.
Yeah.
Their reported pain level, their physical function, how well they could move and do things, and their overall assessment of their condition. So it's quite a high bar for saying the treatment worked.
Okay. And I know they also restricted pain relievers during the follow-up to keep the results clean. Why was that so important, maybe different from past research?
Oh, it was absolutely essential. They knew that stronger pain relievers, things like NSAIDs or even opioids, could easily mask the perhaps subtle effect of the radiation itself.
Right, it muddies the water.
Exactly. So during the first 4 months of follow-up, those types of drugs, NSAIDs and opioids, were prohibited. Patients were only allowed to use acetaminophen, Tylenol, as a rescue medication if needed.
So very basic pain relief only.
Yes. And this strict control meant that if a patient did meet those responder criteria, the improvement was much more likely to be clearly attributable to the low-dose radiation itself, not just other drugs they were taking.
Okay, the moment of truth then. Let's look at the results after 4 months. What did the data actually show using those stringent responder criteria?
Right. This is really the aha moment of the study. In the group that got the low-dose 3GG regimen, 70% of those patients met the responder criteria.
70%. Wow. That sounds really impressive. How does that compare to, say, other non-surgical treatments we have now, like maybe cortisone shots or hyaluronic acid injections?
It's a very strong number, yeah.
Wow.
Especially in a trial with controls this tight. But the real comparison, the crucial one, is against the placebo arm of this specific trial.
Okay, so how did the sham group do?
The patients who got the sham treatment, the placebo, they met the responder criteria 42% of the time.
42%. Just from thinking they got the treatment. That really underscores the intense power of the placebo effect in OA, doesn't it?
It absolutely does. And that 42% response rate, it confirms why these sham-controlled designs are just non-negotiable in this specific research area. You have to account for it.
But the key is the difference, right?
Exactly.
Yeah.
Crucially, the difference between the 70% success rate in the 3G group and the 42% in the placebo group, well, that was statistically significant. The math showed it wasn't just chance. The LDRT was undeniably working above and beyond that placebo expectation.
Okay, and what about the group that got the very low dose, the 0.3G?
Yeah, interesting finding there. That group showed some benefit, about 58.3% improved. But statistically, scientifically, they couldn't prove it worked any better than just getting the sham treatment.
So it wasn't significantly different from placebo?
Correct, which really helps to isolate that 3G regimen as the effective therapeutic dose. It seems that's the amount needed to actually drive that clinical relief beyond placebo.
So what does this finding actually mean for the millions of people living with knee OA? Where does LDRT potentially fit into the treatment landscape, and I guess who is the ideal patient for this?
Okay, so we need to be clear about the mechanism, or what we think is the mechanism. LDRT isn't regrowing cartilage. That's not happening.
Right.
Its benefit, we believe, comes from suppressing the local inflammatory process. It seems to inhibit specific inflammatory signals, cytokines, within the joint itself.
So it's an anti-inflammatory effect locally?
Yeah, that's the thinking. Therefore, the treatment is probably best suited for patients with mild to moderate disease, people who still have that underlying inflammation driving their symptoms, and critically, who still have preserved joint structure.
Okay, so LDRT is definitely not a magic bullet for someone whose knee is already, severely damaged, maybe bone-on-bone arthritis.
No, absolutely not. If the joint structure is physically destroyed, radiation isn't going to regenerate tissue. That's not what it does. However, for the right patients, those with mild to moderate disease. The potential goal here is pretty transformative.
Which is?
This approach could potentially delay the need for joint replacement surgery, maybe by months, maybe by years.
And that delay, I mean, that could be life-altering for someone who's currently in their 50s or 60s and facing that prospect.
It really could. Now, the research team is very clear on this point. This should be integrated into overall care. It's not meant to replace things like weight loss or physiotherapy or even existing medications patients might be on.
So it's another tool in the toolbox.
Exactly. It has to be part of a thoughtful, combined treatment plan. Something decided through, shared decision-making between the doctor and the patient.
We have these encouraging 4-month results now. What's the next critical step for this research? Where do they go from here?
Durability. That's the absolute key question now. They are currently finishing up the 12-month follow-up analysis to see how long the effects of this single round of treatment actually last. Does it hold up for a year or more?
That will be crucial.
Absolutely. And beyond that, they have plans for larger, real-world pragmatic trials. Those will look at specific patient subgroups who benefits most. And also, importantly, they plan to conduct health economic analyses.
Ah, the cost question.
Yes. Comparing LDRT's cost-effectiveness directly against ongoing treatments like injections or long-term medication regimens, that's vital for figuring out its place in healthcare systems.
So wrapping this up, the major takeaway here seems to be that a specific low-dose regimen of radiation 3GG provides statistically significant pain relief and functional improvement for moderate OA. And crucially, it proves its effectiveness against that powerful placebo effect, offering a much-needed middle ground option between just pills and major surgery.
That's the essence of it. And if we just circle back for a moment to that health economic point you raised, it really poses an important question for you, for everyone listening, to consider.
Go on.
If a single, apparently safe, non-surgical treatment like this can effectively delay the need for joint replacement, which, let's face it, is one of the most expensive and invasive common procedures in modern medicine, well, how profoundly might that shift the global standard of care? How might it change the health economics for literally millions of OA sufferers over the next decade? That's a potential change that could really redefine chronic pain management as we know it.